Who will be the first speaker?
So please, just a few words, if you allow me to give a few words about this webinar. If I can, Fed.
Just 10 seconds, and I will let.
Okay.
Who will be the first speaker?
Be online.
Yes, yes. You would like to try your slide, Stefan?
Yes.
Okay, please, Fed.
Yes, please, Professor.
Share your screen. Can you share your screen?
Yes, and if you allow me to say welcome to everyone, and good afternoon from Morocco, from wherever you are, good afternoon, good evening, or good morning, and welcome again to the 31 edition of the Morocco webinar series. Thank you for attending and following our webinar series. Welcome to Professor Stefan Florian from Romania and Professor Miguel Reyes from Spain. Welcome to our panelists, my dear friend Jeff Ntalaja from Kinshasa, from Rabat Yazad Boudreri, my dear friend from Hospital Specialty of Rabat, and Professor Mehdi Kalkouri, a well-known neuropathologist in Morocco. On behalf of the Moroccan Society of Neurosurgery, welcome to all participants, and good evening, Professor Abadi. Good evening, Professor Khadar. And you have the mic to introduce Professor Stefan Florian. Welcome.
Thank you, Fed. Thank you very much for your great effort. I know that you just leave the department to start this webinar. Thank you very much for what you are doing. So we are of course pleased and honored to have to receive during this 31st webinar our two guest speakers, Professors Miguel Reyes from Spain, Malaga, and Professor Stefan Florian from Romania, and our panelists, as already introduced by Fahd. And I will ask our panelists, please, Professor Jeff Natalja, Professor Karkouri, and Professor Yesad Edriri, to, of course, participate and push the participant to debate and exchange their different scientific experiences in order to benefit from the participation, both foreign and national speakers. And I would like to thank them very much for having accepted our invitation today. So allow me today to introduce my good friend first, Stefan Florian, because I'm so sorry, Miguel. First, we will start because he had some commitment after this webinar, and he asked us kindly to give him the part in the first. Professor Stefan Florian is, of course, our friend for a long time, and he's a great neurosurgeon from Romania. It gives me a great pleasure and honor today to introduce him as a first speaker. And he's from, I said, Romania in Cluj. He's graduate and postgraduate from Cluj in Napoca in Romania. He was appointed in many academic positions, professor and head of Department of Neurosurgery in the same city since January 2006. And in 2012, he was appointed as Vice Dean of the university at the medical school. And in January 2020, when I have the chance to visit him as an invited speaker, he is the president of the Senate of the same university. It means like a president of our university or chancellor in USA. He was involved in several educational courses also in the European Association of Neurological Surgeons through a lot of European countries, and was elected as a vice president of Southeast European Neurosurgical Society. He is well-known leader neurosurgeon, not only in Romania, in Europe, but around the world. We had together a wonderful moment in the WFNS when he served as member of the Constitution and the bylaws of the Committee of the WFNS. And in 2017, we were elected together, and he was elected as second vice president at large of the WFNS. He is active member of the World Academy of Neurological Surgery. Once you know, it's all of you that is a prestigious association, and also active member of many international societies. Past president of the Romanian Society of Neurosurgery, corresponding member of the Romanian Academy of the Medical Sciences, founding member of the Romanian Neuro-Oncology Society, and our talk today is about malignant glioma, and we will understand what means the title Quo Vadis. Many people ask me about what is it, and I tell them, I answer them, you have to wait to the webinar for having the answer. And a founding member of the Romanian Neuro-Oncology Society. He is doing an outstanding scientific work by founding many societies and study groups, for example, for neuroprotection and neuroplasticity, Romanian Society of Plastic and Reconstructive Microsurgery, Romanian Brain Council, Romanian Spina Bifida and Hydrocephalus Association, and a president honorary member of the Romanian Minimally Invasive Neurovascular Group. He is the author of the over 67 published scientific papers, author and co-author of 9 books. I hope that the books that we write together will be published soon. And of course, author of 49 chapters in books and treatises. During his amazing career, he had received more than 10 awards and distinctions. One of the most prestigious is Sanitary Merit Order, rank of commander, awarded by the President of Romania, Ion Iliescu, in 2004. Summarize your CV, my friend, is not easy task. I try my best to do it close as much as possible to your talent and high skill. Thank you so much for being with us, and you have of course the word. Thank you.
I thank you. I'm very honored to be part of this very educational initiative promoted by Moroccan Society of Neurosurgery. I gladly participate in every meeting you organize because I know they are of highest level possible, and it's a great honor for me to share my experience along with you and your invited speakers, and also with all the attendees to these courses. Thank you again for very nice presentation and for invitation. And I would like to start my presentation, which is, in fact, it was larger, but I shortened because we have some time limitations. So I hope you see my screen, yes?
Yes.
Yeah.
Yes. So Quo Vadis, where we are going now. So what's the future in malignant gliomas? Because I don't have any conflict of interest. The first reported case of glioma resection was performed by Rickman Godley in 1884. So more than 1 century later, the patient's outcome remains poor, with marginal improvement since 1970s. It's a continuous fight. It's a continuous war against these tumors, but up to now, we don't have We didn't find the magic bullet in order to kill this. So in the last reported, the mean survival it's up to 18 months in the large majority of the publication, and this is quite similar with those reported 20 years ago. Despite all the improvements, all the technical improvements we had in the last 20 years, we didn't succeed to obtain too much. So in the last years, the major improvement, it's the new classification of World Health Organization of the brain tumors, especially of the gliomas. And this is a tendency to better define the type of the tumor in order to individualize the treatment. This is important for the patient. It's important for neuro-oncological field, generally speaking. But how, up to now, how it influences this classification, our attitude as neurosurgery, it's not very, very clear. But we should be involved in research and in improvement, not only of the surgical aspect of treatment, but also in all the aspects in order to add some chances to our patient. So for the pathological, for the first row, for the pathological aspect, nowadays we have the MRI and spectroscopy, which are, and the imagistic, it's highly suggestive, but for I don't know, I don't see the entire screen because of the I see you all. Can I reduce this in order to see?
Fahd, it is possible, Fahd?
Yes, I succeed, yes.
Yeah, you can just
Yes,
put in
yes. Now, so
like this.
now there are more and more studies trying to define better and to connect the imagistic with the genetic classification, and in that manner to assess the patient's individual prognosis, the so-called radiomics, and allow the prediction of distinct molecular genetic textures, the so-called radiogenomics. So all these improvements are introduced in order to better define the pathology and to have an individual, a personalized treatment. So, you know, I used to say to my students, when I started neurosurgery, I learned in my school here in Cluj that we are treating patients, not disease. After that, in the last 20, 30 years, it was introduced the evidence-based medicine. That means that we are treating disease and not patient. Now it's a movement of paradigm toward, again, to the patient. So we are more and more applied to the individualized treatment toward the patient itself. So in preoperative evaluation, we can estimate that based on the imagistic IDH, wild type, grade 3 and 4 share poorly defined margin, mixed signal intensity, and pronounced enhancement. That these are especially the glioblastoma and the anaplastic astrocytoma. And also the MRI spectroscopy, perfusion analysis, amino acid positron emission tomography can improve the diagnosis accuracy and allow us to make an evaluation of the diagnosis and to improve this diagnosis. And also, based on these imagistic tools, we can detect the infiltrative tumor tissue beyond the conventional MRI-defined borders. So we can evaluate the true biological tumor volumes. All these are introduced in the last 2-3 years. But the question is, should we redraw the patient treatment from this, and especially from surgery, based on these findings? Are radiomics and the radiogenomics more important for a neurosurgeon than location, extension, volume, functional data, and clinical status? And it's not only my impression, but also based on the literature up to now, radiomics and genomics cannot be used as a substitute for a molecular analysis of tumor. So we should have at least the biopsy. And from a surgical perspective, there is, for us, now they still remain standard T2 weighted FLAIR and contrast T1 weighted are the most important imagistic tools, along with the fiber tract, functional MRI, and this offers to neurosurgeons the most important data regarding the resectability. But also based on this imagistic, there were published some predicting surgical outcome scores, and this could be used in order to evaluate preoperatively and to discuss with the patient. But they have some drawbacks because they are only based on the imagistic findings, no multifocal lesion included, and they have no reference to the clinical status of the patient. So in the future, we should accumulate all these clinical data with the imagistic, and in order to better prognose the treatment. Because if you consider only this score, imagistic score, you will never recommend the surgery for a patient, 71 years old patient with this lesion, which is highly suggestive for something anaplasic, something malignant. So we enter, because the clinical status of the patient was good, and she asked for surgery. So with the transcallosal approach, you see here interhemispheric transcallosal approach. This is the corpus callosum. We made 1.5 centimeters. We entered directly the tumor and progressively debulking and piecemeal removal of the tumor. We succeed to completely, at least on imagistic, to completely remove the tumor. And the patient, despite the diagnosis, which was a glioblastoma, hypothalamic glioblastoma, the patient is still alive. So again, based on the scores promoted, especially by neurologists, neuro-oncologists, you only indicate some biopsy for this kind of tumors, in which we perform a radical resection through a supracerebral infratentorial approach. You see here, we are trying to preserve the veins, especially the anterior vermian vein, in order to avoid the complication. So again, having a natural route up to the lesion, we progressively remove the tumor by undissect all the structures around, and then we completely remove, as you can see, the tumor. And again, the problem of surgical indication. This is a diffuse pontine glioma. So usually the indication, the surgical indication, it's not accorded to the patient. But in some cases in which there is a clear delineation, and the tumor has some lateralization. It's recommendable to try at least to remove partially the tumor in order to have at least the diagnosis and to add the adjuvant treatment. So we perform a surgery through a retrosigmoidian approach, and I will go a little bit faster. And we succeeded quite satisfactory reduction of the tumor. You see here after the radio and chemotherapy treatment, 2 years after the operation, the lesion was stable and unfortunately recurred after 3.5 years, and the patient lived after the operation only 4 years. So along with the adjuvants for surgery, and I will present briefly later these adjuvants for surgical results, for improving the quality of life. Another important tool is surgical experience. And speaking about surgical experience, in my last 20 years, we made a retrospective study. I performed 1,767 surgery for gliomas for almost 1,450 new cases along, and these are the total number of surgery for brain tumors performed by me in the last 20 years. The peak for all the gliomas was in the first, for low-grade gliomas was in the first decade you see here, but for the high-grade glioma, as in other large series in the fifth and sixth decade with a significant male predominance. Speaking about the high-grade gliomas, we operate 839 new cases, and 72, almost 3/4 of the cases were in between the fourth and the sixth decade. So this is the interval of risk for high-grade gliomas, at least in our experience. Again, a significant male predominance. Like you know, all know, the glioblastoma was the best represented in 60%, and along with the anaplastic astrocytoma, they represent, at least in our experience, 80% of the high-grade gliomas. And our goal is almost always gross total resection, and we succeed this in many of our cases, in the large majority of our cases. So this is an example of our understanding of gross total resection. It was an intraventricular anaplastic astrocytoma, a very rare case of anaplastic astrocytoma, in which we perform a transcortical transcortical approach. Nothing very special. We open the sulcus and then we enter up to the ventricle. You see here, we are using ultrasonography, and this is the moment in which we are locating the tumor with the ultrasonography, and then we enter the ventricle. Once you are in the ventricle, the things are quite simple, because with progressive removal of the tumor, we succeed a complete removal, and the tumor was stable for at least 2 years. This year, unfortunately, recurred, and we lost the patient, despite the fact that we tried again to operate. So, again, speaking about the gross total removal, this patient was 68 when we operated on her, and you can see this was the perioperative, and then the immediate postoperative MRI after the treatment. There, you see here a very small enhancement lesion, but it was stable, and the patient is still alive after 6 years. So certainly, in some instances, we are planning only subtotal resection, like in this brainstem uh, glioblastoma. This is again a very rare case, 30 years old girl with multifocal brainstem glioblastoma. We only perform a retrosigmoidian approach and a subtotal resection of the tumor. You see the immediate postoperative MRI. So entering in the region where the tumor was evident, we progressively reduce the volume, and it was quite well differentiated by the brain normal tissue. So it was not so difficult to remove the tumor, but not completely. We knew that it was quite impossible in such a case to completely remove. So in some cases, we plan a subtotal resection. So generally speaking, the role of surgery, it's decompression, and the recommendation of the European Neuro-Oncological Association, it's to perform a maximum safe resection whenever feasible in all patients with newly diagnosed gliomas. But considering that with surgery, we cannot cure the patient, the prevention of a new permanent neurological deficit is more important than the extent of resection. This is in their recommendation. Another objective is to have a pathological diagnosis from the biologically most active part of the tumor, and to create some favorable condition for the adjuvant chemo and the radiotherapy. Other objective is to prolong survival, because we know that with a complete resection, we can enhance the survival, overall survival, with up to 8 to 6 months. And also, we can improve the quality of life of the patient, because also in our experience, more than 85% of the patient had a period of improvement immediately after the surgery. And another role is in research. We are offering the material for the research for the researcher, and we as a surgeon should be involved in the research programs in order to maybe to discover something new, to have new tools in this unequal fight. And also in education, because these are in many centers the training field for young neurosurgeons. So I will offer you some example for prolonging the survival. This is a 20 years old lady with gliosarcoma. We operated 9 years ago, and she is free of symptoms and free of tumor after 9 years. You will never see from the beginning, from the beginning, which patient will be the lucky one, the lucky survivor. So that's why, in our opinion, you should do your best in order to remove the tumor and maybe to prolong more and more the survival of the patient. In this particular case, it was anaplastic ependymoma, again a brainstem. In the first operation with a posterolateral approach, we enter, you see here, it's the tonsils. Just beyond tonsil, we identified and progressively debulked the tumor. You see the posterior roots, the C2, we preserve them, and with a gentle aspiration with
Ben? Ben?
Excuse me, Professor Florian, I think
Connection?
we lost him.
Connection problems, yes.
Yeah, what there is.
Mhm.
What can we do?
Is there a
wait,
problem with microphone?
we just have to wait a few seconds, I think. We don't have any other solution for that.
It's come from him.
Mm.
Maybe we can.
Yes.
Discuss.
I will send him a WhatsApp. Yes, you can start this discussion maybe with the other panelists and our guest Miguel and all the attendees.
Yeah, if you
Just
permit, I
to-
think the message that Professor Florian was giving is that is the importance of the reductive surgery for
He's back.
He's back. Super.
Professor Florian, we don't hear you.
Can you unmute? Okay.
Yes. Thank
Now,
you.
yes. Can you hear me now?
Yes.
Yeah.
Apologize for this. You
Don't
know,
worry, it's happened.
I think not only the coronavirus is working here. So I will again start with the.
Sharing your screen.
Can you see here?
Yes.
Yes.
Yes. So it's a debate. Whenever a gross total resection, it's better than the biopsy or a subtotal resection. So yes, it's a large meta-analysis demonstrate that there is a significant improvement in overall survival, and comparing biopsy with subtotal, there is no survival benefit of subtotal resection over biopsy alone. I really don't think so, but these are the data from the literature. So we also made a study based on our series, and we demonstrate that with gross total resection, we can add, comparing with subtotal resection, we can add 5 additional survival months. So, and this was in the last study even better with 3 additional months. So surgery, it's not so easy. It's risky. There is a risk of surgery, and this tumor can be large or sometimes multifocal. They are intense vascular, so we have to fight against the hemorrhage, but also to preserve, like in this case, to preserve the normal veins and arteries, and to remove only the tissue, the pathological tissue and the pathological vessel. Sometimes they are infiltrating the vascular wall and also the choroidal plexus, like in this particular case. And certainly we know that infiltrate the brain beyond the contrast. And not all the surgeons which are dealing with high-grade gliomas are experienced neurosurgeons. As I mentioned, this is the field of training. Having the poorest prognosis, this is the field of neurosurgeon and young neurosurgeons. And this is also an explanation for what there is such a large discrepancy in between the survival rate of different series. So talking about the risk of surgery, we have here a case with a butterfly glioblastoma in which we perform complete resection, but unfortunately, she developed a huge edema. We were forced to perform a bifrontal craniectomy, and we lost the patient after more than 30 days after the operation because of multiple complications. So it's not an easy surgery, but also there are some rumors regarding the potential potential role of precipitating the evolution of a otherwise slowly growing tumor. This is a case with two lesions, one in thalamus and the other one in the frontal cortical lobe. We followed the case for some months, but because the patient developed some seizures, we decided to address to this peripheral lesion, not to the thalamic one. So we performed the surgery, and it being a cortical lesion, I don't know how much time do I have. Do I have more? Naja, please advise me, how much time do I have?
Oh, 20 minutes, but it's not matter. You can have a few.
Okay. So you see here we dissect subpially, and then we preserve both veins, large veins, and we completely remove the tumor. And unfortunately, after a couple of months, 3 months, there was a recurrence, but also another lesion. We again remove the tumor, both tumor in the same anesthesia, but in July, in 3-4 months, recured, but the patient still survived 2 more years. So the key points for surgery for superficial lesion, neuronavigation, it's a very efficient tool. It's helping us a lot. But in absence of neuronavigation, you should closely follow the MRI images and finding the cortical landmarks and the large drainage veins, disposition and orientation of the gyrate, and some external landmarks. In superficial lesion, we are recommending a large craniotomies in order to see all the margin of the tumor, and they have usually a gyral appearance. This is another very, very rare case of posterior fossa glioblastoma. We perform an unilateral approach on the right side, and the tumor was located in the cerebellum and superior part of the cerebellum, being superficial, at least in the superior part. So we identified and then progressively remove the tumor. I will go because it's nothing very special. You see here a complete removal with a very good hemostasis. We are performing these surgeries usually in a sitting position. We have a quite large experience, and during the surgery, I don't need too many instruments. So I use bipolar aspirator, microseizure, microdissector, and tumor forceps. These are the main instruments in order to remove the tumor. For deep-seated lesion, you should adapt your opening to the location, and we take advantage of natural routes like transsulcar approach, interhemispheric fissure, or Sylvian fissure. And in this case, it was a thalamic anaplastic astrocytoma. We perform with affected side down in a park bench position. So we had a lot of space, and we completely succeed to completely remove the tumor with the same technique. Piecemeal removal and debulking, hemostasis. You see, I largely use the coagulation And I am sincere when I say you that I rather prefer the bipolar and the aspirator than the ultrasonic aspirator. So this was the case, and she's still alive more than 2.5 years. So for adjuvants for surgery, intraoperative ultrasound, we are largely using this for deep-seated lesion. We also tried the contrasted ultrasound, but I am not very satisfied because you don't have additional data, despite what it's written in the articles. 5-ALA, it's very well known, but in Romania it's not approved yet. Fluorescein guided dissection we used in vascular pathology, but in malignant tumors, I am not pleased with what we obtained. Nowadays it was introduced the intraoperative photodiagnosis with talaporfin sodium. I only mentioned because it was mentioned recently in the literature. We are using neurophysiological monitoring in some selected cases. I'm not in malignant tumors. I do not use the awake craniotomy, and we don't have intraoperative MRI. So we should base our more and more on our experience. So how many times we should operate? This was a patient with 2 lesions, so we perform removal of the tumors in the same session, and at 12 months you see only a small contrast enhancements here, and in 15 months he was free of symptoms, but he died 2.5 years later. And this is another case with of 31-year male with initially it was an anaplastic astrocytoma. We operate firstly, then after 1 year it recur. We reoperate in March in 2013. Then he presented with this corpus callosum involvement, but we wait a little bit. But once the tumor increased in volume, we decided to re-enter in November 2013, and it was stable more than 6 months, but 1 year after he developed this butterfly glioblastoma, and we stopped along with after the last operation. He died in January 2. So we performed more than 4 operations for this case in order to prolong, and up to the last operation he was in a very good neurological condition, and it was young. So we demonstrate that surgery of recurrence improved the quality, the survival, the overall survival, and in patients younger than 65 years, the survival of 2 years, it's up to almost 40% of the patients. So I will now wonder if there a progress with all these new developments. So in a search, and it was published in 2016 on a retrospective study of MD Anderson Cancer Center, and they obtained with all these new technologies. They obtain a survival of median survival of 13.4 months. And in our last study, in our last series of 246, in patients younger than 65 years of age, our survival rate was 13 months. So we are almost there with no other surgical adjuvant than intraoperative ultrasound, intraoperative monitoring in selected cases, and some surgical experience. So what is the progress? So if you looked at the literature in the history in the beginning of the surgery for glioblastoma, Maxwell published in 1946 that such operations for glioblastoma are almost always ultimate failure because a high percentage of glioblastoma extended into the opposite hemisphere, and there is therefore regress. So in the largest series published in that years, in 1962, Ley et al. In glioblastoma in his series has a median of survival in patient operated and treated with a röntgen rate therapy 15 months, 1 year and 3 months. So the addition of temozolomide to radiotherapy for newly diagnosed glioblastoma resulted in clinically meaningful and statistically significant survival benefit with minimal additional toxicity. That was the study that introduced in our practice temozolomide as a standard treatment, chemotherapy. And it was published in 2005 by Stoop and co-workers. And you see here, the median survival, it was up to 14.6 months. So it's really an improvement if you look to the series of Ley, from 15 to 14.6. But certainly there are benefits for this treatment because overall monthly cost of care varied between 2,000 and 3,000 euros. Median cost effectiveness ranged from 28 to 38,000 euro per life of year. So there is a benefit. So in conclusion, this is the list of the high-grade gliomas operated in the last 7 years. You see here, these are only the survival. This, in the last row, it's the date of disease, their death. So this, only 5% of our cases in the last 12 years are still alive at 5 years. The question is, have we done enough for them? For sure, we should do more for the future. The take-home message is an improved prognostic evaluation that also includes the emerging field of molecular, metabolic, and imaging-based biomarkers will certainly help to identify the surgical procedure that fits most to the needs and the limits of the individual patient. Surgery is the first and the most important step to keep walking. The failure of actual therapies suggests that we are maybe on the good path, but we still have a long way to go. The future multimodal treatment will consist in patient-tailored therapies because all people are different, and so are gliomas. And maybe we should learn more from the great survivors. And this is the end. You see, not many things have been changed in the last 500 years, because 500 years, this is a picture very well known, the stone. 5,000 years ago, they still used for neurosurgery sitting position. The priest was then and now one of the closest collaborators of neurosurgeon. Neurologists, which were full of science, are still looking to neurosurgeons, how many things can they do. Thank you very much for your attention.
Thank you very much, Professor Stefan Florian, for this outstanding lecture and for all your message and thoughts about malignant gliomas. Thank you so much. I think that we will stick to the program and we have discussion by the end of the two talks. What do you think, Professor Abedi?
I think for Stefan, you will stay with us till 8. That's
I will stay if you have some questions, because I have to move to the next meeting.
No, before 8. Okay, so we will. Go ahead.
If you have some questions, I'm
Go
glad
ahead.
to respond now.
We can
have a discussion now.
Yeah.
Yes.
Because the two talk is a little bit very different. The talk of Miguel is a little bit different. So I think we can open the discussion now.
Yes, Professor Rodriguez, I sorry I interrupt you during your explanation or talk when Professor Florian was trying to get connected again. So if you can manage discussion. Thank you.
So in my turn, I would like to thank him for his outstanding presentation and thank him also for stressing on the importance of surgery for the high-grade gliomas and reductive surgery, because as he has shown and stressed and insisted on, we cannot only rely on radiomics to predict the outcome of patients. So we need a specimen, and only after surgery, then we can explain why this patient succeeded to survive more and more years, and this one could not. And as on the examples or the patients, many variations can be seen. Patients with small remnants can survive much more years than others, and ones with complete resection that show a recurrence and early recurrence. So the only way that we can use in order to help these patients is try as much as possible, and whenever it is possible also, to try to reduce their pain, try to reduce their tumor size, and then we'll see the biological behavior of this tumor later on.
Yes.
Thank you.
That's our conclusion also. Firstly, you should operate, and I don't have enough time to present, but in my series I only have 3 biopsies. I rather prefer to remove as much as possible. If it's possible, complete, it's the best, but the subtotal, in our understanding, it's at least 75–80% of the tumor.
May I have a question and a comment, please?
Yes.
I'm not totally agree with you about surgery, because we do surgery when of course it's possible without damaging for the patients. But knowing that it was malignant tumors, glioblastoma, I'm meaning, it's because in your talk, it's a really amazing talk, but in my opinion, we need to separate many histological malignant glioma. For example, there is a difference before glioblastoma, between glioblastoma, between low glioma with the evolution with anaplastic astrocytoma and with the ependymoma. This is why you have. I think this is why we have. In my opinion, you have maybe a big number of prolonged survival, because we have also the prolonged survival we have three cases that have more about 10 years, and we was very surprised, but we never understood why this type. And I'm speaking only about the glioblastoma. And my question is, when you shown us two examples, two examples. The first one, when you have a butterfly glioma, glioblastoma, and you do surgery again after recurrence. It's too much. You take too much risk for this patient, and we know actually that and currently that the quality of life is very important for these patients, knowing that they have a small survival, that they need to be in good quality of life. This is why, in our opinion, the middle line, the middle line and the deep situation of the malignant glioma, we did only biopsy, and then we send them to the oncologist. I want to have your answer, but the comment of our friend Professor Karkouri about this, the difference between these different types of malignant glioma. Thank you.
So you have right, but I put here many examples of different types of malignant gliomas in order to underline the role of surgery. I have many studies based on pathology, based on the evolution. Now we are in Romania, we introduced this new classification, and we, along with my neuropathologist, we have the largest database on on brain tumors with in Romania, and maybe one of the largest in the Europe, because we have more than 400 frozen glioblastoma samples. Mm-hmm. So we are performing all kinds of studies. I'm not confused about and I didn't mix this because I only want to underline. Regarding the butterfly glioma, I only started to operate butterfly glioblastoma in the last maybe less than 10 years, because there is a discussion, a large discussion with relatives, with the family, with the patient, sometimes even with the patient. And I'm not proposing the surgery with all the risks. I consider the neurological status, the Karnofsky score, how the patient is able to support the surgery, which is quite general. But starting to operate, I observed that in at least half of them, we obtain the same survival rate like in other locations. So at least in my experience, there are cases in which they deserve your attention, surgical attention, in order to, if it's not too large, if it's not. Unfortunately, I'm not afraid to present also the complication, because when you decide to operate a patient like this, there are many risks. In the other case, it was a young boy, 31 years old. And I discussed with the parents for the last operation, in which the tumor involved the corpus callosum. Sometimes it's so hard to discuss with the patient and to refuse the last treatment. He begged me, please, doctor, you made him so well so many times. Please try once again. Mm-hmm. What's your answer?
But
Yeah, and I understand. I explained him. It's difficult. The risk is so high. We cannot obtain almost nothing.
The same result.
And he begged me. We want him to see him alive, even in bed. We want him alive with us. So, can you refuse a case in which you were involved for 2.5 years? No. And in the last, and then we stop. So the decision, I not operate all the cases which are addressing to me.
Mhm.
And in many cases, I explain to the relatives and what are the consequences, what are the risks, what are the benefits. And certainly for glioblastoma, I explain clearly that there is no chance for cure, but they still, and this is also a cultural aspect, you know? They are trying. Maybe you can solve something, you can obtain something until something is discovered and they will be cured. Fine.
We are all attending.
You are facing, we all surgeons, we are facing with this problem. So, yes, but in time, I can tell you that I'm not afraid to operate.
Okay, thank you.
Thanks.
Professor Khakori, maybe you
Yes.
have a comment?
Yes, thank you.
Yes.
Thank you, Professor Florian, for this very nice talk. And congratulations. I'm jealous that you have 400 frozen samples of glioblastoma. I think I will move to Romania and work with you.
Not in Romania, in Cluj. In Cluj.
Okay. I think all this complexity and the heterogeneity that you have been discussing from your side as neurosurgeon completely reflects also in the heterogeneity that we as neuropathologists are facing in the diagnosis of glioblastoma. I think we are just starting to unveil the diversity behind the glioblastoma. Until recently, we were talking about a glioblastoma, but go with the knowledge going further. We know today that there are so many glioblastomas in reality. We have just started to discriminate between them with the IDH mutation, and I was reading in one of your slides that the wild type IDH wild type glioma, they have a poorly defined margin, they have mixed signal intensity, and this is a complete reflection of their aggressive behavior. We know that the wild type group do much worse than the mutated group. So I think that what we are going towards is we are going to what we have done in like, for example, in breast cancer, when we are able today to break down the breast cancer into molecular groups, and treatment and surgery is done according to the group. I think we are just at the beginning of glioblastoma, but I can totally relate to all the difficulties you have during surgery from our side as a neuropathologist.
Thank you very much, and I'm very pleased that Nadia invited you as a neuropathologist along with us, because I started every day in the morning with a discussion with our pathologist. We discussed the case that I previously operated. We discussed the aspects. So at 9 o'clock, before I enter the operating theater, I have a discussion, phone discussion with my pathologist, which is a very close collaborator. So I really rely on his diagnosis, and we discuss the future steps. And also we are doing a lot of research. I didn't have, but I have, maybe in future I will present a topic related to the role of neurosurgery and neurosurgeon in research, which is very important.
Thank you for so much.
Just one moment.
Yes, please. May I ask the third panelist to give us his experience in Kinshasa, please, Jeff. Before to give the floor to the other questions, Professor Azhari, Professor Etbali, and others. Yes, I do. Continue after the discussion.
Thank you, Madam Abadi. Thank you, Professor Flo. I just want to ask one question. When I understand your presentation is very, very nice, but I want to know just, I understand one thing is very important for me. You say that the great extent of reduction has been shown to improve overall survival, because when you, there's no survival benefits or subtotal reduction or over biopsy alone.
That was data from the literature, but yes, from the literature.
For your experience also is very good.
But based on our experience, you can improve with the greater removal. You can improve the quality of life, and overall survival for sure. And we demonstrate. And I maybe it will be accepted. I sent to publication our study in which I underlined the role of surgery in glioma.
Okay. That is I want to just to ask, to know. It's good for me.
Thank you.
So I would like then to give to Professor H. Ben Ali. He wants to give a comment. So Professor Ben Ali, please, can you make your comment?
Good afternoon and good evening, everybody. Thank you very much, Professor Florian, for this very nice lecture. Unfortunately, I missed the first part of your lecture, and I have a question about wake surgery. What's your experience about wake surgery for malignant gliomas, and what do you think about this indication?
Well, I mentioned that I don't rely too much on awake surgery in high-grade gliomas. I use it in cases with low-grade gliomas in high functional areas. But generally speaking, I don't like too much. I rather prefer to have a cortical mapping, to have a collaboration with our neurophysiologist in this, because awake surgery, you need for sure a very well-trained team, and the psychologist, the psychologist, the logoped, it's a crowded operating room, and you know, I started neurosurgery almost 40 years ago. I was not yet a resident when I started to operate, and here in this department, and at that time we only had one neuroanesthesiologist in our department. He was not able to be 24 hours a day, 7 days per week. So a large number of cases were operated with local anesthesia and with an awake surgery. Trauma cases, even benign tumors. So I have a lot of experience and not very pleased with. So whenever it's possible, and it's I feel that it's needed, I use. But in high-grade glioma, I rather prefer to have a cortical mapping and to have a larger removal of the tumor.
May I just add a comment? In high-grade glioma, you have the edema, you have the brain.
Yes, it's difficult.
It's completely different than
completely different from
you need time to select the localization of the tumor, or with a high-grade tumor, you didn't have enough time to do awake surgery. This is why, in my opinion, it's not indication. And I tried once time, and I regret it because we have we stopped all the procedure and we continue as usual. Thank you.
So I have to apologize because they are waiting for me for the next meeting.
Stefan, I have just
Hi,
a
hi.
question to you. Stefan?
Maybe the last comment from
Okay.
Professor Azhari, it's possible?
Stefan, it's nice to see you.
Nice to see you.
Nice you to hear other things than vascular surgery from you.
Well, I do almost everything except spine.
Okay, what we do in my institution is to use the neuronavigation, ultrasonography, and everything, and we see with our oncologist, Dr. Naim he's present in this webinar, and we discuss if molecular biology is EDH mutation is okay, and no MGMT is going to do the chemodal and radiotherapy. And for many times we make just decompression, not total gross total resection, just decompression, because we discuss with family, and what they say, I always say that he want to keep him autonomous and to have the best result of quality of life. So it's very important to know before. That is my question for you, because it's very important to know the histology and biology. Some neurosurgeon, you said that there's many people is different. Glioblastoma is different, but neurosurgeons are different.
Yes.
So some neurosurgeon make biopsy, just biopsy, small biopsy, and went to the molecular biology, and after that they make gross total surgery or partial surgery. It depends of the molecular biology. What do you think, Stefan?
So if I well understand, yes, I never push too hard the luck of the patient in order to remove completely in every condition. So certainly, my goal is also to have a autonomous patient with a neurological good condition to be able to be, and many of them are reintegrated not only in the society, but also they restart their practice. So I have many patients in which after surgery, they were reinserted in their social life, in their business, in their previous activities. So it's really very important. But I present some cases in which there are maybe some of them were extreme, but I am in favor of reduction as much as possible of the tumor without damaging the patient.
Okay.
When it's possible. Not always your intention is matching with the result, because you have morbidity in every series. But in the large majority, you obtain an improvement of quality of life, and the patients, majority of them, are happy, and their family also. What I learned from this pathology, it's to appreciate every single day of your life.
Okay.
This is the message.
Thank you.
Thank you very much. It was a great pleasure, and we will meet again in the next.
Yeah, of course.
Okay, Stefan. Thank you very much.
Thank you, Stefan. Thank you very much
Thank
for your for accepting our invitation, and good luck for your next
Thank you very much.
meeting. Thank you. Bye-bye.
Bye.
Maybe we will ask our guest Miguel what he think about this subject before he give his talk. Miguel, please.
Yes. Yes.
Please.
Do you want me to start?
Yeah. What you think about this problem with the glioma and the surgery, aggressive surgery or not? In some locations, as we said, butterfly or in the deep in the brainstem, in the thalamus, in the you know, according the quality of the life of these patients, knowing that they are not the over survival is really very
Thank you.
small.
Well, my philosophy is just trying to be very aggressive. If you have the possibility to make a big removal, preserving the quality of life, and the operation makes sense, just trying to prolong survival. If not, I'm very cautious and I move to the biopsy, let's say, point. Because butterfly glioma, I don't know the experience of the other colleaagues, but butterfly tumor, usually the patient has some sort of deterioration previously before the operation. If you touch the tumor a little bit, you will not increase the survival and you will very much impair the cognitive situation of the patient. And you will impair the patient, and the patient, those patients are, let's say, disabled patients from the cognitive point of view. So butterfly glioma, we never operate on unless there is a young patient with a big disproportion, you know, between the component at the temporal, at the frontal lobe, very big, and the component at corpus callosum, very small. So it may be reasonable to do some gross removal. Usually this is not the case. So butterfly, pure butterfly, I do only biopsy. I'm also cautious when going to deep-seated areas, because you will not gain anything, and you have many things to lose. This is my understanding. I very much follow the 90% resection. If you can get 90% resection, or more than 90%, in a safe way, maybe you are going to prolong the survival of the patient by means of the operation. If not, be very cautious. This is my understanding.
Totally agree. Thank you, Miguel. Maybe Jeff, it's your.
Okay.
Yeah.
Can
you introduce our Professor Miguel Reyes, please?
Yes, sir.
You know
Thank
what?
you. Thank you.
I asked Jeff to introduce you because, you know, he was one of the, of course, the awarded of the WFNS award. So as the president of foundation of WFNS, and you contribute a lot to help African people to had this WFNS. Thank you so much. Please, Jeff.
Thank you, Professor Abadi. Thank you first for inviting me to participate in this webinar. Very good webinar in Society of Neurosurgery. Thank you for all of my master of Moroccan Society. And it's a great honor for me to introduce Professor Miguel. Professor Miguel is the chairman of Department of Neurosurgery of Carlos Aya University Hospital. He's also professor of neurosurgery of Malaga University, director of chair of advanced neurosurgery at Malaga University, and the past president of the Spanish Society of Neurosurgery. He's also the chairman of World Federation of Neurosurgical Society Foundation and vice president of World Academy of Neurological Surgeon, member of American Academy of Neurological Surgery. We have a lot of quality of Professor Miguel, but I will go. He's also member of Royal Academy of Medicine and Surgery of Andalusia, and corresponding member of Royal Academy of Medicine and Surgery of Spain. He's member of the International Advisor Panel of the Journal of Neurosurgery, and many other journals, member of editorial board of Neurosurgery Review, member of editorial board of Neurosurgery Post Section, member editorial board of Irian Journal of Neurosurgery. That is all of quality of Professor Miguel. Today we have a great honor to introduce him and to understand what he will speak about advanced tools in high-grade glioma fluorescent guided resection and nanotherapy.
Thank you very much, Dr. Talaya, for the kind introduction. Thank you very much. I'm very flattered and very honored just because of this invitation on the side of the Moroccan Society of Neurosurgery. Thank you, Naya, my very good friend. Thank you also, Dr. Hassani, and all the other friends I'm seeing here. We always say that we are a very good friend, very close friend and neighbor, and this is completely true. We are in the heart of each other, and well, it is a great honor just to participate in this interesting webinar. I just shared my screen. I hope you can see the whole screen. Can you see that? Yes?
Yeah, yes.
Okay, thank you very much. So I will focus in two perspectives. One of them is a current perspective incorporated to the work of glioma surgery. Another one is one of the forthcoming promising technologies maybe to increase survival in that kind of controversial and difficult pathology. I will start with the fluorescent guide resection. And just as a brief introduction, this is the editorial of the last issue of the journal Surgical Neurology. After that, the surgical, as we knew, it did disappear. And this is the editorial from James Ausman. Does gross total removal of a brain tumor produce greater longevity? This is the key issue. And this is something very important when talking about malignant glioma, preoperative, postoperative, after 6 months. This is something we have seen very frequently. Dr. Florian, by means of his excellent and detailed presentation, showed many cases like this one. So it does make any sense or not. This is something we have to discuss about. And let's see the summary of the past century. The summary of the past century could be just in one word, that was pessimism about this kind of operation. If we look at this paper published in Neurosurgery in 1994, we will see through this paper that radical resection was done in less than 20% of the cases, and very frequently this radical resection was so limited because of the inability to define the tumoral margin of the lesion. But this is a paper very well known, 2011. Dr. Nader Sanai, the group of Mitch Berger in San Francisco, and extended resection for newly diagnosed glioblastoma. Basically, large series, 500 cases, improved survival if resection was over 78%, even more improved the survival if resection was over 95%. So the answer is yes, and this is one of the paper of our group, published this year in World Neurosurgery, Dr. Marta Troya Castilla and some other colleagues from Seville and from Malaga, impact of early reoperation in the prognosis of patients operated on for glioblastoma. It means that in the cases after the operation, some tumor was left behind. In selected cases, if you go ahead and you do a reoperation during the period of the patient still admitted, increasing the resection, you will have a more prolonged survival. So this is something just supporting the idea that, let's say, total removal of the lesion, if we may say, because we never achieved a real total removal. This is like in chordoma case, but I mean gross total removal, meaning that in postoperative MRI, you won't see any uptake of contrast enhancement. You will prolong the survival of the patient. And this is also something that has been proved for anaplastic glioma. So in summary, just answering to Dr. Osman, yes, radical resection does improve survival. And second, radical resection is very much related to the difficulty to identify the tumoral margin of the lesion during the operation. And this is the key issue, and we will see very briefly what kind of intraoperative technologies we can, use trying to define the tumoral margin, improve the resection, and improve the survival. We have intraoperative MRI, high cost, low applicability, useful for surgical planning, very used to define the tumoral margin, but this is something thus far not available, nor even in, let's say, public center, big public center, not even in private center. We are truly fortunate. This is the project for Carlos Saya University Hospital hybrid intraoperative MRI. And this is the way nowadays we can try to take advantage of a useful equipment, because if you try to do intraoperative MRI with low field equipment, this is something wasting time and wasting money. But this is the hybrid project that make, this useful tool something, amenable for improvement of resection and satisfaction for patient and physician. This is our project, fortunately approved and to be a reality in 2021. But this is not a standard tool, and we have to, use another adjunct tools like intraoperative ultrasonography, low cost, useful for surgical planning, low specificity. We can see these images, very bad for the definition of the tumoral margin. And in this context, we just see how 1 decade ago, more or less, fluorescent guide resection came. What is the base of this technology? The base is that the tumoral cells of many tumors, not only glioma, not only malignant glioma, some other cancer, but talking about malignant glioma, glioblastoma, usually metabolize 5-aminolevulinic acid to protoporphyrin 9, that is a fluorosphore, that is to say, a molecule that after receiving sunlight is re-emitting light in a different length wave that can be identified by means of sophisticated filters in the microscope. Here we see one difficulty, because the systems available are really expensive and are unfortunately limiting this wonderful technology that, to our mind, is helping very much in glioma surgery. So this is the way we have to just emit some sort of blue light. There is some re-emission by means of the fluorescent phenomenon, and this re-emission of altered length wave is, seen by the surgeon and assistant and people in the operating room by means of some sort of sophisticated filters. So this is the rationale, and this is the way, with white light, you can see that way the core of the tumor, and with the application of this blue light and all these sort of fluorescent guide techniques, you can see a difference between the tumor and the surrounding area. This is, by the way, a metastatic ependymoma in the skin, and see how even ependymoma is uptaking this sort of, let's say, fluorosphore. Why is only used in glioblastoma or malignant astrocytoma? Because this conversion to protoporphyrin 9 is very regularly done in the context of that tumor. You can see that in sarcoma, you can see that in some carcinoma, but the probability of getting this phenomenon is not very high. You can see one of the typical lesions, and we will see how the fluorescent phenomenon can be seen. This is how we can just start to see the phenomenon at the subcortical area. You can see how bright the phenomenon is because we are just operated on in some area with a lot of cells, malignant cells. Insofar as you have blood in between your site and the lesion, or insofar as you have a necrotic tumor, you will not see the phenomenon so clearly. We have finished the resection, and this is what we can see in some standard case. We have removed the tumor, maybe we have finished, but using the white light, you are not completely sure about. This is white light, and this is the moment where the phenomenon and the technique has the most useful meaning, because when you are dealing with the core of the tumor, everybody is sure that they are dealing with solid tumor. But what we are looking for is just to identify the tumoral margin of the tumor. So if I will move forward, and let's see, when we just use again the blue light, we can see some areas that are completely clean and some pinky areas that are still corresponding with infiltrated tumor. Just very important to distinguish between this normal appearance, pinky appearance of the peripheral infiltrated lesion, and I will go back to the bright light and see the difference between the solid part and the infiltrated part. This is how you can see the lesion. This is the tumor after the resection. And also important to mention that our experience and what the literature is reflecting is that fluorescent guide resection is also useful for recurrent malignant glioma. And we have many of the papers are focusing in survival. That's okay. This is a very important issue. But we have to use fluorescent guide resection not only as oncological tool, but also as intraoperative tool. This is a patient with recurrent tumor. This is very well seen at the MRI, but take into account that nowadays the recurrence of the tumor is seen before the lesion has some mass effect. So in those cases of infiltrated nascent recurrency, it's very important to intraoperatively see the gliotic area and see the infiltrated area. And see this case, I will move forward. This is the sticky area of the gliotic plane. But if you put the blue light, you can see how this gliotic plane is actually infiltrated plane. So this is something that is leading you and navigating you inside the tumor if you want to do in a safe area a radical removal. See also how the cortex, this is midline, is infiltrated by the tumor. So this is something important. This is after simple case, but it's important to mention that for recurrent glioma without mass effect, intraoperative fluorescent guide resection may guide you and use a real neuronavigation. Important to mention that this is something to be combined with all the other intraoperative tools. Of course, with intraoperative monitoring, this is a paper from the prestigious department of our very good friend Marcos Tatajiva, just reinforcing the idea of the intraoperative monitoring in the resection of glioma tumor in eloquent areas. as I mentioned before, this is what we can see with a white light and see how, fluorescent guide resection may help you to identify where the most active part of the tumor is. And also important that in what we initially could interpret at low-grade glioma, sometimes we can see some small, tiny uptaking areas that are representing actually areas of malignant, the differentiation of the tumor, and the use of 5LA can help to identify those areas. You can be, let's say, more aggressive in that part because we are just identifying the most aggressive part of the low-grade glioma that may just convert the tumor into a glioblastoma over time. Also important to mention that in some center, before just waiting for postoperative CT scan, they want to be sure that inside the operating room, the sample they took are belonging to the tumor, and in that way, the sample can be, after administration of 5-ALA, this sample can be seen inside the operating room as pathological without waiting for the CT scan in order to see the accuracy of the procedure. So, of course, very important. Does 5-ALA has some impact on resection and survival? It was the core and the target of this paper published long ago by the group of Walter Stammer, who is the father of the useful application of this technique. And in summary, we can see in the light of this paper that first issue, the resection with the 5LA is 65% versus 36% with a white light. And second, progression, 6 months progression free survival is 41% versus 21%, in both cases with statistical significance. Similar rate of adverse effects, so giving sense to the use of this technique as intraoperative tool for increasing of the resection and so increasing of the survival. We just participate in a very similar cooperative study in Spain, 2011, with a very similar conclusion. And in summary, we guess that these intraoperative tools is very reliable, very easy to be used, and very helpful. And this is some comparison of the different intraoperative procedure to increase in a safe way the tumoral resection. We can see intraoperative MRI, ultrasonography, neuronavigation, intraoperative monitoring, 5-ALA, the way they can help to identify the tumoral margin and the way they can help to preserve function. That is to say, a summary, our goal to combine effective resection with safe resection, effectiveness and safety. Intraoperative MRI, very good for the definition of the tumoral margin, not good for presentation of the function. Ultrasonography is very weak in both senses. Neuronavigation is good for planification, but nothing else. Intraoperative monitoring, very useful for preservation of the function, and 5LA, very useful for the definition of the tumoral margin. And this is with this small table, we can try to figure out how to combine the different techniques for the good of this, safe and aggressive tumoral resection. So 5-ALA, useful to define the tumoral margin, simple and reliable, cost-effective, unlike intraoperative MRI, for instance, very low rate of adverse effects, useful in recurrent tumor, and positive impact on survival. I think this is something very important. The second part of my talk, trying to be almost in the 20 minutes assigned, is regarding another outlook for tumoral resection in high-grade glioma. We will just invest less than 10 minutes talking about nanotherapy, that is iron oxide nanoparticles to treat high-grade glioma. We can see one of the statements Dr. Florian mentioned about the around 14.6 months mean survival has not almost not been modified. Unfortunately, at 5 years, more than 90% of the patients with glioblastoma have died. And in summary, no significant progress in survival of GBM in the last 20 years, and mainly talking about not de novo glioblastoma, but talking about recurrent glioblastoma in which radiotherapy cannot be used in many instances. What is the role that nanotherapy is playing? Nanotherapy is allowing for the molecular effects of hyperthermia. Hyperthermia can improve the biological effect of chemotherapy and can also improve the biological effect of radiotherapy. That way, more number of tumoral cells can be killed, and also some sort of effect of the on the vascularization of the tumor, and of course on the tumoral cells can be seen by means of this hyperthermia. This is basically the intimate mechanism. I don't want deeper inside that because this is not my field of expertise, but in summary, we just assume that the nanoparticles are small enough to go through the brain-blood barrier, and after the action of hyperthermia, some sort of processes are done, just leading to apoptosis of the tumor. We will see that there are many papers dealing with that in the last decade. We will see that there are many nanocarriers for several physical and biological properties. Magnetic nanoparticles are used, and among them, nanotherm is the one just already approved for this use of treatment, nowadays approved for the treatment of recurrent glioblastoma. And you can see more or less the molecule. I'm not an expert on that, I won't. But see that the size is very small, 12 nanometers, that to my mind is something really, 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 really small. This is the nanoactivator, because you use the nanoparticle, we will see how, and after that the nanoactivator is producing some external magnetic field that is, let's say, activating or increasing the effect of the nanoparticle. We do the tumoral resection. Example number one, open surgery. We will just apply the nanopaste that is using the nanoparticle of iron, and you can see some intraoperative view. You can see the effect at the MRI. And important to mention that among the limitation of this technique is the non-possible use of MRI because of the artifact of the iron particles. So we have to follow the patient with CT scan, and by means of this sophisticated positron tomography, that is the 18F fluoroethyl tyrosine, as you can see here, that is showing uptake in case of persistent tumor, and in that case you can see the nanopaste and the disappearance of the lesion. And in cases of recurrent tumor without mass effect or deep-seated area, and following the discussion that very appropriately Professor Naya Elavaya came up regarding when do a major operation and when to do only a biopsy. For those cases not amenable for reoperation, you can make some interstitial application by means of stereotaxy of neuronavigation in making some injection of the nano particles as you can see here. It could be in that way, interstitial application, the process, the nanoparticles are injected, the nanoparticles are diffused among the tumoral cells. The patient is put under the nanoactivator activity. Some heat is generating, and finally, the tumoral cells are being killed among other mechanisms because of the heat, because of the high temperature in the core of the tumor. So tumor is inactivated, and by the way, the protocol includes 6 times application of this tool, trying to improve survival. This is one of the papers of Walter's tumor, just insisting in how intracavitary thermometry combined with radiotherapy and also chemotherapy can improve the inflammatory reaction and may improve the immune response against the tumor. And you can see a couple of papers regarding the experimental use and also the clinical use of this technology that is hopefully to be something helpful. And you can see the summary in first tumor recurrence. You can see the improvement in the mean survival that is more than double expected without this technology, and also after diagnosis of a primary tumor from the very well-known 14.6 from 14.6 to 23.2. And some consideration about this recently approved technology in Europe. There are 2-3 centers in Germany, another one in Poland, and we are in the process of implementing this technology in the forthcoming months. The pandemic of COVID just did stop the project due to logistical issues, but hopefully we are going to provide this benefit to our patient in the next future. So in summary, nanotherapy is improving survival because hyperthermia has demonstrated the capability to act synergistically with the other conventional therapies as chemotherapy and radiotherapy are. There are several possibilities for intelligent combination of regimes that are in the way of improving survival. And of course, the next step will be the approval and the use in de novo cases, trying, as I mentioned before, not only from the experimental point of view, but also from the standard point of view, be used in the treatment of glioma. This is my last slide, trying to not take much of your time. I just wanted to show one very much settled technology in the setting of the glioma surgery. We just started more than 10 years ago with this technology. And we also wanted to show one promising technology that we are very much embracing, trying to do as much as possible for the benefit of our patient. Thank you very much again to the Moroccan Society of Neurosurgery. And I'm very happy we are so far in this moment because, you know, as far behind as February, we were together in the Abulcasis meeting, just enjoying our company, respective company, and having some tea and giving and shaking our hands to each other as a very good brother we are. Thank you very much again.
Thank you, Professor Reis, for this very interesting talk about these tools that enhance the survival and the quality of life of our patients. Thank you for having accepted to participate in this webinar. Is there any questions or comments from the panelists from the floor?
Maybe Professor Khamdishi first, and after I have comment.
Professor Khamdishi.
Thank you. You heard me?
Yes.
Good evening, everybody. Thank you very much, my dear Miguel, for your nice presentation and didactic and summarized in really focused on important points that are needed in our topic today. By the way, and I'm sorry that our colleague Florian is already gone. I couldn't make a comment on his presentation. But I think that what you have said to us, for me, is really completing the answer to his question, Quo Vadis, which was the title on his presentation. Because this the answer to know where we are going with this problem of malignant glioma is certainly in this new ways you mentioned to improve surgery, the total or the subtotal removal, because the total is almost impossible in glioblastoma, as you know. And also this new therapeutic ways like the nanotherm therapy. But I think that to complete the answer to this question, Quo Vadis, we have absolutely to consider the recent progress of the molecular biology. They are very, very important. And we have seen, all of us, some patients who are having survived more than 5 years. And Dr. Florian has shown us maybe in his large series some cases. And since we have these markers of molecular biology, I tried in just some cases, because we have got them no more than 5 years ago, and this is the main problem of this markers of molecular biology, because they are very expensive, and not all our pathologists are also familiar with that. I don't know if our colleague neuropathologist, yes, he's still here.
Yes.
Comment. In just 3 or 4 glioblastoma, I was controlling for many years, more than 6-7 years. All these 3, we controlled their genetic mutation, and their, for example, IDH1 and 2, mainly 1 was mutated. So I think that this progress in molecular biology should be taken with all what you have mentioned to improve the surgical resection, because there is no doubt, demonstrated now for more than 50 years, that more you remove the tumor, more you get you prolong the survival. If we add to all this aspect, I think that we can maybe have more clear idea about how to deal with this tumor, and how to explain to the patients in the future. But the basic should be that we start with the classification, the new classification, with what our neuropathologists are telling for us. It's very, very important. So I'm very happy to have heard your presentation, my dear Miguel, and thank you very much for all this information for all our colleagues.
Thank you very much, my dear friend. Thank you.
Professor.
Maybe? Yeah. Thank you so much, Miguel, for this wonderful and very useful and very amazing talk, because you know, I personally learned many things with your talk, because it's for me it's a few in our country's future is the future. I hope that we can have all these technologies in the near future. My question is about for person-guided resection. My question is it more useful, for example, for using in the not high but low grade glioma, because we know that the first line of the treatment in the low grade glioma is the surgery and the total resection and surgery. So maybe it's more useful because we need to have a total resection. Otherwise, and when we are faced malignant tumor, you said it, you told it that even you let remnant, little bit remnant, we are not sure that that will be a recurrence in how many months, 1, 2, 3, or 1 year. Sure, it's I'm sure that it's very useful, but it's more useful, in my opinion, in the low grade glioma. What's your opinion on this?
Well, I cannot be more in agreement. And as a matter of fact, the consideration of the current guide for management of low-grade glioma, when we just consider some incidental low-grade glioma or some lesion that hasn't caused any symptom, only seizure, what to do, observation or removal. It has been, you know, a classical dot. Now the guidelines are stating that we have to remove this low-grade lesion, although apparently indolent, maybe are not growing in the future, and so on. So why? Because of a small foci of malignant transformation that may lead the tumor in the future to glioblastoma or malignant astrocytoma. So I am completely in agreement with you that first, on the basis of the removal of that kind of tumor that may lead to the cure in some cases, we have to be sure that any foci of, let's say, uptake can be removed, because these small malignization points are going to, you know, to be those giving the worst prognosis for the tumor. So I do completely with you in that. So nowadays, instead of using 5-ALA only for high-grade glioma, insofar as we see, let's say, low-grade lesion with a small point of uptake, we are just in favor of using 5-ALA.
But what we see in high glioma is different than the low grade glioma in the yeah, it's different.
Yes, absolutely.
Only the malignant cell, not benign cell. This is sure. Okay.
Right.
And the other questions about you told us about you put it in intrasite when you operate with craniotomy or with biopsy, stereotactic biopsy, but sometimes you use it external like radiotherapy, or it's always you use it like radiotherapy after you put the
Well,
product inside.
You
Sorry,
mean
but
whether
I don't understand very well the technique.
you mean regarding nanotherapy?
Yeah, of course.
Okay.
Yeah, it's
Yeah,
of nanotherapy, not of the fluorescent guided.
Just going back to your comment, that is very important. The visibility of the 5LA intraoperatively is very much related to the density of the tumoral cells. It means that low-grade glioma, first of all, doesn't metabolize to protoporphyrin 9, and second, the density is very low. In high-grade glioma, glioblastoma, you have a very high density and you will see this red color. Insofar as you are going to the peripheral area, just infiltrated area, you will see a pinky area. So this technique is not yes or not. It depends on the cellularity. Going back to the nanotherapy, well, we don't yet have experience. We have been studying very much, and we are very much in contact with all these issues. But I don't have yet any personal experience. There are maybe 4 centers in the whole Europe, but the technique seems to be complementary to the previous radiotherapy and chemotherapy done. You have to use the nanoparticle. You have to put the patient in the nanoactivator, and since then there are 2 possibilities. One of them, only hyperthermia, that is, the use of the magnetic field, increase of the temperature in the tumor. It does have, only that technique does have a cytolytic effect, has an effect of cell killer for the tumor. If you, on top of that, apply radiotherapy, you will have even more, let's say, tumoral, anti-tumoral effect. But the issue is that sometimes when giving the nanotherapy, you have already consumed all the possibilities of external beam radiotherapy. Maybe for that cases, what we use in some cases, according to the size of the lesion, we use some boost of radiosurgery. That is something controversial, but is sometimes all you can do for the patient. So in summary, you have to inject or put the nano paste in the tumor. Then the patient is following this protocol of several sessions of hyperthermia by means of magnetic field, and yes or not, on top of that, radiotherapy may be given.
Thank you, Miguel.
Okay, Professor, we have been asked to take discussion.
Yes, you hear me? It's okay?
Yes.
Yes, yes.
Yes, good evening, everybody. Good evening, my colleague, Professor Rice. It's a very nice presentation. You summarize exactly the situation regarding the problem of malignant glioma. And I totally agree that the last 20 years, there have not been a very good improvement in the results. And congratulations for what you are doing in your department, but you are trying to introduce a new technology, new techniques to improve the resection rates and importance of this resection. This is my comment. I have just a question regarding the nanotherapy you use for thermotherapy. I think this you are certainly aware about that the technique of thermotherapy is something that has been used from the 90s, and by using the laser radio thermotherapy. And I remember I was involved in work with Peter Black in the 90s using laser thermotherapy. And the problem with this thermotherapy is that the distribution of the temperature in the tumor, it seems that it's not regular. And what is your experience with this nanotherapy? Because with the thermotherapy using the laser, all the tumor just recur at the border. and they need either a retreatment or chemotherapy. It is clear or that this just you can't rely on just one technique, but radiotherapy, chemotherapy, immunotherapy, all these tools have to be used to improve the survival. What's your comment about that, Miguel? Thank you for your nice presentation.
First of all, glad to see you, my friend. Thank you for the question. Well, I like to insist, I don't have yet any personal experience. We are just in the process to implement that technology, but we have been studying very much about. And this is a very clever issue because nanotherapy just has a very important step that is the nanoplan. So the nanoactivator, before releasing the magnetic field, has some planification like in radiosurgery. And this planification is done by means of the fusion of previous CT scan, MRI, and ideally PET scan. So you have to add all these three sources of image, CT scan with contrast, because this is something like, you know, the X-ray technique that is going to allow you for the further comparison, because you cannot do MRI. But before the use of and the release of the hyperthermia, you have to make a planification. This is like an in gamma knife. You do a planification about where you are going to deliver the temperature, because temperature cannot be very high. Temperature is varying between 40 something and 50. 50 has some ablation capability. 40 something has some thermal effect, but no matter to say that all these techniques has potential damage for the patient. And if the nanopaste is very intense and the hyperthermia is also very intense, you will have postoperative edema, like in a huge boost of radiation therapy. But very important question. Thank you.
Thank you.
Yeah. Yes, you said it really.
Thank you, and thank you for Moroccan society to give us the opportunity to see our friend Miguel. Thank you, Miguel, for your outstanding presentation. I have one question for you. Now in Casablanca, in our hospital university, we are getting the IRO, the CT scan, perioperative CT scan. Right. And I have one idea. I want your opinion about that. We have the 5-ALA, and we have the scan. We want to start a study to make the good precision of 5-ALA. To make 5-ALA and to put the patient in the CT scan and to see what is if there's some concordance between 5-ALA and we know that glioblastoma is going out of the tumor. It's very important, you know, because our colleague radiotherapists want to make irradiation in the bed of the tumor. And it's very important to know if there is some cells in the bed of the tumor. If it's possible, and it's not functional area, it should be more interesting to remove it with surgery than radiation. And with MRI, I think you could make this study, Miguel. It's very interesting to make a relation between 5-ALA and the image of MRI, and to see which one is better. You understand my suggestion, Miguel?
Yes, thank you. I understood very well, and this is a very clever question and very important concept. And it has been already done. Reason why, well, we are happy about the possibility of intraoperative MRI in the future, hopefully. But honestly, I had the chance because of architectonical issues. But, intraoperative MRI is not the best tool for definition of the tumoral margin of glioblastoma. And as a matter of fact, it has been already compared whether, imagine we have removed the tumor, we see at the intraoperative MRI, just inside the operating room, we have seen that the uptake ring has disappeared. If you go back to the patient and we put the blue light, you will still see pink areas because the infiltrated areas of the tumor can be identified by 5-ALA and cannot be seen at the MRI. Can be seen as flare image, but flare image sometimes is edema, sometimes is infiltrated peripheral area. So in order to better assess the extent of removal of the tumor itself, 5-ALA is better than MRI, and hopefully, I'm afraid, better than CT scan. This is my understanding.
So it's not necessary to have MRI and CT scan in the operation room.
You will have both things?
No, it's not mandatory to have MRI or CT scan in operation room.
Yeah, but I mean, in the best scenario that is intraoperative MRI. Intraoperative MRI can be negative, you don't see anything. And if you put the light, you will see still pinky areas seen by means of fluorescent guide resection. That means that the image of the tumor is better seen and further and seen beyond by means of 5-ALA. This is my understanding. And as a matter of fact, there has been one or two studies, one of them by Ricardo Díaz-Valle from Spain, another colleague from Spain, comparing, what happened in the survival of the patient when you remove the bright red tumor, and what happened when you remove the bright red tumor and also the pinky area. If you remove also the pinky area, the survival of the patient is larger and is longer. And in the same way as some other studies showing that in postoperative MRI after glioblastoma resection, if you manage to safely remove the flare area around the tumor, even survival is increasing, reflecting that you are also removing the infiltrated area. This is my understanding.
Thank you, Miguel. Thank you.
Professor Reyes, we have some questions from the chat if you would like to give some answers. First, we have a colleague who is asking what is happening to normal brain tissue when you hit the nanoparticles to kill tumoral cells. Is there any technique to sensitization to tumoral cells?
Well, what happened in the
normal brain tissue?
The normal brain, okay. Temperature, high temperature can have some damage for the cells. And this is what we are looking for the tumoral cells. Reason why we use, apparently the technique is using a very focused hyperthermia in an area also focused by the nanoparticles, and that way you can increase the heat in this area and provoke some cytolytic effect. If you apply hyperthermia, you will damage the brain. It depends on the temperature. At 60 degrees, 50 degrees on the normal cells has some damaging effect.
Okay. Thank you for your answer. We have another question from Professor Mahjouba Boutarbouch, who is asking how often do you go for a second surgery for recurrent glioblastomas, and as well as long as patient is still in an acceptable condition, clinical condition, and also about the gamma knife surgery, for radiosurgery for glioblastomas.
Thank you. Very good question, both. First of all, we take into account, I think this is something linked to the very appropriate discussion that Dr. El Abadi just arose before. Well, what we take into account? We take into account, first of all, the situation of the patient, the current situation of the patient. If the patient is at bed or the patient has some cognitive problem, we do not go for another resection because the patient, unfortunately, is not going to come back to a good previous situation from the cognitive point of view. So, very important issue is the quality of life in the moment of recurrency. Second issue we take into account is how long did it take since the previous operation to the second one, and how the situation of the brain is, of course. So talking about the time, we have, this is very arbitrary, but around 9 months. If you operate a patient and the patient has the tumor back 2 months after, it doesn't make any sense to come back to the operating room. If, the time elapsed is around 9 months, 7 months, 1 year, of course, it makes sense. Also, second issue, where the recurrency is. Is the recurrency amenable for big resection, 75, 90%, or 100%, if I may say? Resection, if so, in a safe area, go ahead. If you are going to reoperate the patient to do a very partial removal, it doesn't make any sense. And third, is there another possibility, another chance? What is the chance? One of the possibilities is radiosurgery. We do use radiosurgery. It is very, dubious whether there is a real effect or not. But we are using that. Some papers are in favor, some other doesn't have any clear idea about the potential benefit. But what we do is trying to give radiosurgery if we understand, we are, guessing that radiosurgery is not going to harm the patient. That is to say, we have a small lesion, not at the brainstem or very eloquent area, because what we have seen that after a standard radiotherapy, if you give radiosurgery, the bigger the lesion is, the higher the risk of radionecrosis. So you have also to counterbalance that. But we do use radiosurgery because if we understand that the probability of having radiation necrosis is not very high, this is the most you can do for the patient.
Okay, thank you very much for your answer. And sorry, I may have a last. Actually, it's a comment or a protocol that was shared by our colleague Badr Bayed, the fluorescein use, and he's saying that this is the protocol of Professor Metellus, using 200 milligrams of fluorescein in order have the peroperation. Is this the same protocol that you're using in your department for your patients?
Excuse me, you are talking about the protocol for fluoresceins. Yes. Okay, we use fluorescein. I think that the dose of 50 milligrams per kilogram is the appropriate, and we use that in a solute. This is something that is the patient about to be to be had by the patient per month, and we use that around 6 hours before the operation. There is some plateau and some level that is kept even 24 hours. That is to say that even in the case you have any problem with anesthesia or some unexpected delay, you can do the operation, let's say 6 hours after the expected time, and you will see the fluorescent phenomenon.
Okay. Thank you.
I think, sorry, he is asking that Professor Metellus used that like the ophthalmologist, I mean, in an intravenous fluorescein, is the same protocol. You know, when sometimes you don't have enough experience with the neurosurgeon. This is I mean, this is his. What is the tricks and tips that Metellus, Professor Metellus from Marseille, who normally do would be with us, but unfortunately he couldn't. I think this is what he sometimes advise.
Sorry, because there was some weakness of are you asking whether we use what is the usefulness of not fluorescence phenomenon, but fluorescein, the one given by ophthalmologists, because this is another.
Yes.
Another
yeah.
Yes, we fortunately we have the microscope with all the fluorescent techniques, and I think that one of the problems with the fluorescein, that is to say the product used by ophthalmologists, the problem is that you use that, you will see something, and the effect completely disappear. You know what I mean? So there is no, if you have seen the medical literature, these are empiric, beliefs, because there is no any regular study showing whether this is useful or not for, let's say, removal, complete removal, impact on survival. So I think there is no consistency in this technique. We use that for some other kind of infiltrative tumors. Imagine we are, with ENT, we are talking about some sarcomatous lesion. They are very good for fluorescein, and we use and to see how things are and whether we have completely removed or not. Not much faith about the protocol. I don't see fluorescein, that is the same product ophthalmologists use, is very useful, and of course is Phyolate is much better because of many reasons.
Asad, there is another question.
I think that's all for chat questions. Okay. I don't know if other participants have some questions or comments.
I have a comment, and then you can close, maybe the session. So just thank you so much for your really wise and elegant message that in one of your slides you said safe tumoral resection and survival in malignant glioma, and you compare the different technologies and between, of course, the radical resection tumoral and of course, the preservation of function. And we say, for example, that intraoperative monitoring is more preservation of function, but fluorescein guided resection is more relevant for resection tumor, totally resection of the tumor, and etc. I mean, neuronavigation, intraoperative MRI, for example, is also more for total resection than preservation of function. And this is a really very wise message. Thank you for that. It's my last comment.
Thank you very much. Thank you very much. It's been a great honor for me just take part of this webinar. Thank you for counting on me. I'm very happy. Well, I'd like to transmit what honestly I think about this kind of operation in these challenging cases. It has been really good for me just to meet my very good friends who are in Morocco by means of this TV, because you know, we cannot shake our hands.
It's our pleasure. We start this cooperation many years ago by creation and foundation of the Mediterranean Society, and I hope that we can see us more and more, and hope and wish you that the situation of COVID would be better in your country, not only in our countries, but around the world. Thank you so much, Miguel, for your participation.
Good night.
We will give the last word for the president of Moroccan Society, Professor Abdel Hakim Nakhdar.
Thank you, Professor Abadi. Thank you, Professor Reis, Professor Florian, for your very interesting talks, and I hope we will see you soon in the next webinar. Thank you for all the attendees and the panelists. And see you next Tuesday. Thank you. Next Thursday.
Okay, thank you. Thank you, Miguel. Thank you, all the participants, all the speakers and panelists.
Thank you.
Bye, Miguel. Bye-bye, Miguel. Bye.
Merci, merci Jeff. Merci professeur Patori. Bonne soirée à tous. Thank you. See you next Thursday. Bye bye.